the ARCHES trial was a phase 3 global randomized study of men who had metastatic hormone-sensitive prostate cancer. Standard of care for these men for many years has been systemic therapy with androgen deprivation therapy, and these are typically men who present de novo with metastatic disease. The ARCHES trial enrolled approximately 60% of these types of patients who had never had a prostatectomy or radiation but started off with their disease process with metastases. About a third of the patients had metastatic disease that had relapsed after local therapy. The ARCHES trial was 1,150 men, and they were randomized 1-to-1 to enzalutamide plus ADT versus ADT alone. The primary endpoint was called radiographic progression-free survival. So this is the time that a man has before he develops worsening metastatic disease or death. For me as a clinician, some of the important practice-changing elements of ARCHES were actually some of the subsets. So the pre-specified subsets of patients that had a substantial benefit with enzalutamide over ADT alone were those men who had actually completed docetaxel for metastatic hormone-sensitive disease. As the audience is well aware, many men with high-volume disease are treated with docetaxel nowadays, and ARCHES allowed those men to enroll. And so about 20% of our patients had docetaxel that completed and then were randomized to enzalutamide. And we showed a 50% further reduction in the risk of progression over time compared with ADT alone. So that's an important practice-changing subset of patients that had a clinical benefit. There was also improvements in the risk of castration resistance over time, and the risk of PSA progression over time, and the risk of needing a second therapy over time. Also importantly, quality of life was very high in these patients to start with. Most of these men were asymptomatic, and they maintained that asymptomatic disease over the follow-up of about 14.5 months in this study. The safety profile was very consistent with what's known about enzalutamide, with mild fatigue, hypertension that was very manageable. Some patients who are elderly do have a risk of falls and fracture, and it's important to pay attention to bone health, to exercise, to home blood pressure monitoring to reduce those risks.
So we find ourselves in an interesting situation at the moment in the setting of M1 hormone-sensitive prostate cancer. Docetaxel added to androgen deprivation therapy is now a standard of care and has resulted in substantial improvements in survival, far more than we see when docetaxel is used in the castrate-resistant setting. Latitude has shown us, similarly for abiraterone and prednisone, in addition to standard ADT, there's a benefit there which is of a similar magnitude. Now we're looking at enzalutamide in this setting as well, so arguably still targeting the androgen receptor, so it was a logical thing to try. Today we heard the first presentation of the ARCHES data, and this has been long awaited. There are some important points to pull out of the study design. Firstly, the primary endpoint was radiographic progression-free survival, and overall survival was the secondary endpoint. The study has clearly met its primary endpoint of rPFS, which is very useful, but we don't actually know for sure that correlates with overall survival yet in this setting. I suspect it probably will, but the study is still fairly immature with only 14.4 months of follow-up, so we really need further information to do that. So where we have a situation where we've already got 2 effective therapies that have been shown to improve overall survival, and we've now got a new agent where we only have evidence for radiographic progression-free survival and not yet overall survival, I think it would be premature to say that enzalutamide is occupying the same space. Now I should declare a conflict of interest here. I am the chair of ANZUP Cancer Trials Group, and I'm the global co-chair of the ENZAMET study, which is a very similar design. ENZAMET is just about to undergo its first interim analysis, which is an event-driven analysis. The difference here is that ENZAMET has as its primary endpoint overall survival. Another point of difference is the use of concurrent docetaxel. So in ARCHES, 18% of patients had received docetaxel with androgen deprivation therapy. That reflects modern practice, but the treatment with docetaxel had to be completed before these patients entered the ARCHES randomised part of the study. So arguably these patients would have had 4 or 5 months of androgen deprivation therapy with docetaxel before the effect of the enzalutamide would be seen. ENZAMET is slightly different. We had an early amendment to that study that allowed the use of concurrent docetaxel with ADT and enzalutamide or standard antiandrogen. So together we hope that both of those studies will provide complementary information to support the use of enzalutamide in this setting. At the moment I think it's still premature to say that this should be adopted into standard practice.
Enzamet is a second study with enzalutamide. I think these two studies will go very well together, with Enzamet being the primary endpoint being overall survival. Slightly different kind of study design than ARCHES, where enzalutamide was given concurrently with docetaxel, a much larger subset of patients with docetaxel treatment in that Australian phase 3 study. We don't have results of Enzamet yet, but I would anticipate, by the end of the year, we're going to have many options for men with metastatic hormone-sensitive disease: abiraterone, docetaxel, enzalutamide, likely apalutamide. We have radiation now to the primary for men with low-volume disease. So men are living longer. That's good news for our patients. We're going to be faced with a wide range of choices. And just like in the castration-resistant setting, some of these choices are going to be dictated by patient-specific factors, payer factors, costs, toxicities, rather than efficacy, because many of these drugs are very efficacious and equally efficacious. The good news with ARCHES is we're seeing now sequential use of therapy may be the most efficacious, particularly for high-volume disease. So instead of an either-or decision, it's going to be a both decision. So docetaxel followed by enzalutamide is where I felt like this was most practice-changing for next week.